Okay, so I present you, I would like to underline again my pleasure to be here. And I do a totally different talk with some technical aspect compared to the Alberto presentation, who was very nice. My talk was about knowledge discovery and predictive model in cardiology. And it was realized and performed with several collaborations that I mentioned here, either a student or colleagues or a clinician. The problem addressed in my talk is that generally we face a large amount of data, and sometimes with no a priori knowledge on this data, either on the data or either also on the patient or individual. And as already mentioned this morning by Philippe, but also by George, we know that it is probably not difficult to decide on instantaneous value, but it is rather better to take into account the temporal evolutions. So the objective of my talk is to show that effectively when taking into account the temporal evolution, we can improve the performance and we can improve the decision. So we have first to perform generally an objective data reduction in order to identify the most discriminative and most informative variable. Remember that we are faced a large amount of data. We try also to identify the relationship between the different variables and to identify group of patient or specific behavior. So in this talk I present two distinct approaches. One based when you integrate no knowledge, and the other one when we integrate some knowledge and using modeling. The general approach is described here. Let us suppose that for one patient we observe a multidimensional time series. Then in this case we try to perform a fuzzy time-space coding. I explain just after what is fuzzy time-space coding. And then we perform a multiple correspondence analysis on a particular dataset, on a homogeneous dataset, in order to enhance some important factorial axes, and then we project the individual into this first factorial axis. What is important to notice here is that this multidimensional time series can be represented by a particular behavior on the first factorial axis. Then after, for the decision, we can use classical techniques such as clustering or using some specific distortion measure. The fuzzy space coding is summarized here. In fact, for the multiple correspondence analysis, we use disjunctive variable. So we have to prepare the continuous variable over the time for the multiple correspondence analysis. We use here free spatial fuzzy window in order to reduce the information. You can divide it in several classes, but we can retain only a fuzzy coding like low value, medium value, and height value. And to take into account the temporal evolution, we also perform a fuzzy coding of the temporal by several windows with an overlap of the window in order to conserve the continuities of the data. So the multiple correspondence analysis, in fact, include explicitly the temporal information. It means that a time window is a statistical individual, and a trajectory will be a patient over all the time window. So I give you just an idea of the methodology, and we have applied that on a patient with cardiac resynchronization therapy, and this patient suffering with heart failure. it is also a good connection with the presentation of Eno and Catherine, because of course the utility of this model is also for telecardiology, of course. So it is well known that the patient suffering with refractory heart failure can be treated by implanted device in place of transplantation, but unfortunately 20 to 30% still remain no responder to the therapy. So that's why we have to use the device in order to collect information from the device and to prevent a severe degradation of the patient, to monitor the patient, and also to identify the non-responder population by an individual follow-up of the patient, either, of course, at the hospital or by telecardiology, as mentioned by this morning. Other objective of the studies was also to exploit, of course, the multivariate data stored in the implanted device, because now this device stores a large amount of data with new sensors. We want to analyze the link between the factorial axis and the variable, and also to perform a clustering in order to identify the evolution of the patient. So in this case, we use a biventricular stimulator with two new sensors, one accelerometer, which can give us an image of the physical activity, and one with a transthoracic impedance sensor, which gives us an image of the respiration and also of the ventilation. The activity level was divided in two states, exercise and rest. The data was in fact a cumulative value over 20 hours recording, and in fact just after the surgery and the implantation of the device, we follow the patient during 3 months, then collect the data. 3 months again, we follow the patient and collect the data, and then 6 months after, we collect again the data. It means that for each patient we have a free record, but we have all the evolution during the 3 months. Here I have represented the behavior of the different variables on the first factorial axis. As you can see, remember that we have faced a large amount of data. As you can see, a lot of variables are in fact correlated. All the low value here and the high value here. And we use in fact 7 variables are stored in the implanted device and 6 are computed after the 7th variable. What's up here, when we use an interpretation, we show that all the part of the plan is related to an augmentation or an increase of a duration in exercise, an increase in the intensity of the effort, and an increase of the efficiency of the ventilation. We deduce that by the interpretation of the variable. And on the other side of the plan, we observe a decrease in exercise, a decrease in the intensity of the effort, and a decrease in the ventilation. And of course, when projecting the individual or the patient into the plan, we observe here, this is the starting of the evolution. You have here all the evolution of the patient. You remember at first we have a lot of data over, it's mean 90 data for 3 months. And now we have a simple trajectory. And what we can say here, 38 patients suffering from refractory heart failure participate to this study, and we collect around 88 records. And what we can say here is that all the patients, due to the previous interpretation of the plan here, that individually has a favorable evolution, and individually has an unfavorable evolution. And it means that now, if a new patient arrives, we can project this new patient into the plan and probably decide and have like a follow-up of the patient. So, just in summary for this study, we start first. We have a synthetic characterization of the evolution of the patient with a large amount of data. We demonstrate the feasibility of the approach to reduce the demonstrability, and we also exploit the data stored into an implantable device in order to follow up the patient. And we observe two distinct approaches. I have another method. So what I would like to show you that with another approach, we can take also into account the temporal evolution. This one use the modeling approach based on hidden semi-Markovian model. In this case, we have the hidden semi-Markovian model can be viewed as a statistical model with an unobservable state, and this state emit observations that we observe. And the states are characterized by probability of transition, probability of duration into the state, and of course the probability of occurrence. And in fact, from time theory, we operate a characterization and we have to take also the decision. As previously, the idea is to take the decision based on the evolution of the time theory, but not on instantaneous value. This is the main idea. So I have just abstract here. So each state represents a portion of the dynamic range of the signal. For example, here you have a particular state affected to this portion of the signal, and observations are generated according to a Gaussian law. This is the same thing for the duration into the state, where the state is of course carried or dynamic. I represent here a particular dynamic that we have to characterize. And the idea is to, of course, characterize the probability of observation and the probability of duration into a state. I would like to mention that large value correspond to, in fact, a low slope, and small value correspond to a sharp slope. And how do you proceed after? After we need, compared to the previous approach, we need a training approach. It means that we're supposed to have a database perfectly annotated, for example here with several dynamic and distinct dynamics that we would like to characterize. And we have to learn the model. Then after, if a specific dynamic arrives on a particular time window, we compute the likelihood of a model will produce the observation. For example, here, it is clear that the model in blue, the likelihood is very low, produce this dynamic. And here, for example, the model in red, which is very stable, produce this dynamic, which is quite stable. Okay, so we applied this method on the detection of apnea and bradycardia episode for preterm infant. Why we do that? Because the apnea bradycardia for preterm infants, it's very dangerous. It requires sometimes invasive resuscitation technique. They made a prolongation of the hospital stay and extra cost. We also mentioned costs this morning. And they are associated to a short-term morbidity and mortality, and some studies have demonstrated for the preterm baby for after a neurological impairment. Actually, babies are monitoring 24 hours, 7 days in the neonatal intensive care unit, and the detection of apnea and bradycardia episodes are done by heart rate monitor, but based on a threshold. And after the first therapy, generally the first therapy is a manual stimulation of the baby. So here you have first to prepare the baby, so record the ECG of the baby, then we perform some signal processing in order to propose a time series and to analyze the time series. For this study, 32 premature babies participate to the study, more than 1 bradycardia per hour, just to have an idea of the baby, because it is only the median weight was 1,235 grams. It means very small baby. And the median age is around 30 weeks after the conception, and the median age was 12 days after the born. So we perform the recording of the ECG, and we extract the RR time series and annotated 232 bradycardia. We use, of course, these annotated bradycardia to train the model, and all the remaining bradycardia was used to perform the measure of performance that I present now. I represent here 3 types of performance. The first one is receiver operating characteristic, classical receiver operating characteristic, with the probability of detection of a bradycardia and probability of false alarm. Here you have the behavior of the strategy used by the monitor. I mean, either a direct threshold, it is in French, but it is a fixed threshold, or a relative threshold here. And here the result obtained when we take into account the temporal evolutions. And as you can see, we have really an improvement of performance. As already mentioned in my introduction about the preterm baby, it is very important to reduce as much as possible the delay for the intervention. So we depicted also the mean time delay versus the probability of false alarm. And as you can see here, for example, for a certain probability of false alarm, the mean time delay is really very significantly decreased compared to the fixed threshold here. And here, when you look at the optimal value, you have also an improvement in terms of sensibility and specificity compared to the traditional approach used here. Here, it's some different parameters we use with our hidden semi-Markovian model, just to look for what are the best ones. So, in conclusion, I would like to mention that I present some study related to multivariate analysis of time series, and where it is important to take into account the evolution and for the diagnosis. We have a distinction of several observations, and of course the proposed methodology, either the first one or the second one, can be applied to other type of signal. And for example, we use it for the detection of ischemia on a Staffstro database on several features, like the ST segment, the amplitude, the magnitude of the airwave, and the RR and the RR series. And just to have an idea about our project on the preterm fund, we are actually currently developing a monitoring station, of course with acquisition of the data, processing of the data, monitoring and representation of the information, and also in order to replace the nurse which simulates the baby, the development of a new sensor based on also on the stimulations. And now, this is the whole version, and the new version is based on Macintosh and easier with the different module. Okay, thank you very much for your attention.
Thank you. Very nice presentation, not easy, but very nice. So, it's open for the discussion. Any question? Well, let's give you a question, just a detail. In the first part of your presentation, you spoke about ventilation efficacy. And this ventilation efficacy comes from what? In which way? Which is the parameter?
The parameter is direct. In fact, the parameters are here. This is the full method, and here. So we In fact, we have, in this case, in the device, you have two new sensors. Impedance, in fact, and the ventilation comes from the measure of the impedance, in fact. And also a gravity, in fact, with the...
I missed that information. If there are no other questions, I do another question is about the second part of your presentation. Mm-hmm. Okay, you spoke about the dynamic processes.
Yeah.
So, in which way you define the time scale for dynamic process?
This is that's why I call that
for the learning.
This is why I call that with a priori knowledge, because in this case we need some information of the data, and of course for the bradycardia it is quite easily. Also for the ischemia, because in this case we have a perfect annotated database with the pre-inflammation, with the inflammation, and so on.
So
in this case, yes. So we can segment that and take the temporal evolution over the time. But what it is important here is that in fact we expect to improve the detection, but by using the evolution, but not by using the value, because as Philippe mentioned that this morning, that from patient to another patient we have sometimes very different value.
Yes.
But sometimes the evolution are the same. This is the main idea of that.
Oh.
And of course it is after for the first application we arrive to the bedside station at home, where the device sends the information to the bedside station and then sent to the hospital in case of decrease.
So you say it's dependent by the patient, of course, in arrhythmia or during the cardiac patient and so on. So the changing of the heart rate frequency is important for the evaluation of the evolution along the time of something, or not?
You speak about
the increase. Okay, if my heart rate is I don't know, 4 beats per second, per minute, I mean that I have in 1 minute I have 40 events.
Mm-hmm.
If my frequency is 70, okay, I have quite a double number of events. So if I have more data, so you consider the time for the evolution of the process, or some...
No, in fact, and that's why I call that also, I don't know if I really clear answer, but that's why also I call that predictive model, because I didn't need to observe all the data to make a decision. And in that sense, it is a predictive.
Okay, thank you.
This is a decision analysis, so you use neural networks?
No. We use, in the second phases, we use hidden semi-Markovian model, which generate a likelihood that an observation was produced by the model. But in the first analysis, if you want, for the decision based on the factorial plan, you can use, if you want, but not on all the features, but on the reduced feature set, you can use a neural network.
Bayesian approach. It's not an a priori
the second one is a Bayesian approach. But in the first one, we integrate no information. We have,
Sorry.
No, video. No.
Yes, you construct of the ROC curves was a posteriori.
Yeah, we construct
the... validate the ROC curve by saying, okay, I take another sample of patients and then I'm trying to look at the threshold of decision. You construct your ROC curve?
No. Here we because it's sometimes very difficult, but you know that. But it's sometimes very difficult to have the consentment of the patient. And in this, and now we arrive to this step because we just finalizing. an evaluation protocol, a PHRC. Excuse me, I say in French so that you clearly understand, a PHRC, and on the 3 hospitals, Rennes, Tours, and Nantes, and they collect all the data.
Okay.
And now we will test our method on this new data set.
Prospective.
Prospective analysis.
Okay, we are late, so
Okay.
thank you.